Okay, great. Well, welcome everyone to my talk at the Low Carb Cruise. How I desperately wish I could be here with you all. Unfortunately, due to some circumstances here at home, Cheryl and I were not able to make it. But I was so looking forward to getting sunburned every day for a week. Next year, we'll make it. All right, so this talk today, a little bit, there's a small part of me that's a little worried that it's a little too technical, but I don't think so. I'm going to trust in my ability to convey complicated ideas and trust in your ability to get them all very, very readily. But this is a concept or an idea that I've wanted to speak about for some time, which is the myths and misconceptions of physiological insulin resistance. Physiological insulin resistance is a thing. I just think it's invoked improperly, particularly when it's invoked in the context of a low-carb diet. Here are my disclosures. I receive royalties from the sale of my book about insulin resistance, and I am a founding partner in a low-carb meal replacement supplement company called Health Code. All right, now, just to set the stage so that we all understand the scope of the insulin resistance problem, a paper was published a couple years ago that found that 88% of US adults are considered metabolically unhealthy. And they based this on people having at least one aspect of the so-called metabolic syndrome. So in other words, people were having, 88%, virtually 9 in 10 adults had some kind of problem in this constellation of issues. And that is to say, another way around, only 12% of people had no negative finding here. Now, the relevance of this with insulin resistance is quite poignant because the metabolic syndrome, which is what you see here, used to be called the insulin resistance syndrome. And this was a topic that I actually, that's a name that I preferred. It was more accurate. Now, beyond just this narrow scope of issues that we consider the metabolic syndrome, insulin resistance is relevant to many, many other conditions. Something that I'll highlight more in a moment is its role in growth. But before we get on to the beneficial side of insulin resistance, I just want to emphasize the negative side. Here on this overwhelmingly tipped side of insulin resistance are all the problems that insulin resistance is known to contribute to. It is known to contribute to Alzheimer's disease, dementia, obesity, polycystic ovary syndrome, and erectile dysfunction, and so on. This is the side that is known as pathological insulin resistance. Whereas on the other side of this battle is physiological insulin resistance. Pathological insulin resistance is when the state is hurting the body. It's a metabolic state that is damaging the body. It is not good. It is not an adaptation that is seeking homeostasis. It only hurts. However, physiological insulin resistance is when the body's become insulin resistant for a purpose. It's helping the body grow. It's fueling. It's a metabolic process that's fueling some growth. So in the time we have together for this talk, there are three key things I want to make sure we've covered. The first, what is insulin resistance? Just a brief review of what the actual clinical definition is from an insulin resistance scientist. And then where does it come from? We need to spend a little time reviewing its origins, especially in these two contexts, pathological and physiological. And then lastly, address the elephant in the room, which is, does a low carbohydrate diet actually contribute to insulin resistance? All right, so firstly, what is insulin resistance? To understand it, it's best for us to zoom into the level of the cell. This could be any cell of the body because every cell of the body responds to insulin. It doesn't matter what the cell type is, it has an insulin receptor, which is a little door that insulin can come after flowing through the blood and come knock on. When insulin knocks on the insulin door, the insulin receptor, it will elicit an action in that cell. I'm calling it an action. That's a generic term, of course, just because the action would depend on the cell. What insulin does in a neuron is not the same thing that it does in a bone cell, for example. Now, one of insulin's most famous actions is the control of glucose. And this is important and something we'll touch on repeatedly here. Now, I'm being careful in my wording to say that insulin controlling glucose is one of its most famous actions, but not its most important, because almost everything insulin does is vitally important. This is a most famous reaction. So when glucose is climbing in the blood outside of the cell, that can't stay elevated for too long. It's harmful to the body. And so one of insulin's effects at some cells of the body, like muscle and fat cells, is to open glucose doors to allow the glucose to come in. Now, over time, all of these actions can become reduced in a cell. That is insulin resistance. So multiple things can happen, but in this narrow paradigm that I'm showing here, some consequences and concurrent events would be that glucose levels would start to climb. So the body's having a harder time regulating the glucose, not surprisingly. But at the same time, this is very, very important, blood insulin levels are higher than they used to be. Now, what was once a polite knocking on the insulin receptor door of the cell becomes a very rude mob-like pounding, all in an effort to try to restore the function that the cell used to have. So there are two critical takeaways in order for us to understand insulin resistance. The first is that some cells of the body are not responding to insulin as well as they used to. Emphasis on some cells. Other cells are responding to insulin as well as they ever did. So it's important for us to remember that it's not an entire universal whole body phenomena. Some cells aren't responding to insulin as well as they used to. At the same time, blood insulin levels are higher. This is the part that is so often overlooked in insulin resistance. There is no condition of insulin resistance in the human body without, or any animal, without elevated insulin. Just to make that very, very clear, there is no insulin resistance without hyperinsulinemia, which is the fancy term for elevated insulin. So this is us understanding or having a common definition of what insulin resistance is. Now, where does it come from? I just want to spend a little time on this. And now we have to tease these things apart, both pathological and physiological. Although up until this point, there's been no difference between them. Both of these definitions apply to insulin pathological or physiological insulin resistance. It doesn't matter. Any invoking of insulin resistance is invoking these two pillars. Okay, now where does it come from? Let's start with pathological, what I've spent most of my career studying. I've noted on here, although I'm not going to take the time too much to elaborate, two kind of phases, metabolically speaking. The first developmental process is when someone has developed insulin resistance, which, if you can see in the vague lines here, glucose is low, but insulin is elevated. That is insulin resistance. And then type 2 diabetes is when the insulin is still high and might have come down a bit, but it is still higher than what it used to be. But now glucose has started to climb. So now it's elevated insulin and elevated glucose. I emphasize these two time points because I think they reflect kind of the two phases in which cells become insulin resistant. I very, very firmly adhere to the fact or the idea that the fat cells are the first cells to become insulin resistant. That's why I've placed them over this first hashed line. When the fat cells become insulin resistant, they then promote the insulin resistance to other tissues around the body. And that when these become insulin resistant, now the person has a harder time controlling blood glucose. And then they flip the metabolic switch from insulin resistance into outright type 2 diabetes. Now that's a topic for another time, how that happens and why it matters. I just want to generally talk about the origins of insulin resistance. There are three primary origins. And when I say primary, I mean to emphasize that all three of these, and I'll talk about them each in more detail, have been shown to cause insulin resistance in the three primary biomedical models, which is isolated cells, like growing cells in a petri dish, laboratory rodents, mice and rats, and humans. In all three of these biomedical models, we can cause insulin resistance with all three of these stimuli. Hyperinsulinemia, so elevated insulin, stress, and inflammation. Now, some of you are undoubtedly thinking, and in hindsight, I should have worked something into this, seed oils. What about seed oils? Seed oils absolutely contribute to insulin resistance, but I can't say that they are a primary cause because I've not seen evidence in all three biomedical models. So you can see the problem. So I would consider seed oils to be a secondary cause, and I'm perfectly content with other people disagreeing with me. It would mostly be a matter of semantics. We would just be using different terms to refer to these things. But the relevance of seed oils, in my mind, most heavily is relevant to the fat cells. Seed oils force fat cells to grow in a particular way that I'm not going to spend time talking about, and they make them insulin resistant. Okay, now let's go through each of these three primary causes in greater detail. So the first one, stress. To understand stress, you have to understand the stress hormones. There is no stress without elevated cortisol and or epinephrine, also called adrenaline. These hormones actually have almost nothing in common except what they do to blood glucose. They have very, very different effects everywhere else in the body, except they share a common effect on the liver, where they push the liver to release any stored glycogen as glucose and to be making new glucose from lactate very aggressively. So they both want to increase glucose. That, of course, puts them at odds with insulin, who wants to lower glucose. So if there is a state in the body where the stress hormones are elevated, for whatever the reason may be, then if it's anxiety or it's a physical stressor because of illness or whatever it may be, if those stress hormones are remaining elevated, that is pushing the glucose up, and that makes it harder and harder for insulin to push it down, and thus the body's becoming insulin resistant. Now, with inflammation, this is something that I've studied quite a bit about, and some of these publications here are in fact mine. To understand the inflammation effects on metabolic function, we have to appreciate the role of cytokines. So cytokines are the prototypical pro-inflammatory or anti-inflammatory proteins that are circulating in the blood. So these are proteins that signal cells to activate immune processes. When cytokines are up, they start to promote a state in a cell that causes insulin resistance. It makes the cell become insulin resistant. There are numerous mechanisms within the cell that actually mediate that insulin resistance. And it's a very fascinating topic. But there are a few different origins of the insulin resistance, like fat cells growing too big, diesel exhaust particles that can be inhaled, cigarette smoke particles that also can be inhaled. Those will increase it. Those are actually two topics that my lab is published on. And then even autoimmune disorders. When someone has an active autoimmune disorder, they will be demonstrably more insulin resistant than when the autoimmune disease kind of subsides. That, of course, is the ebb and the flow of autoimmunity. It's on or it's off, if you will, and then insulin resistance will follow that. Now, the last one is hyperinsulinemia of these three. I leave this one last just because it is the one that I believe matters most. Also a topic on which I've published and many, many others. When the body is chronically elevated or insulin is chronically elevated in the body, it starts to become resistant to that insulin. And this is reflective of a fundamental biological principle, which is that any constant stimulus will eventually lead to a resistance to that stimulus. This is absolutely, unequivocally the case in organisms where chronically elevated insulin has been shown to cause insulin resistance in cells and rodents and humans. There really ought to be no debate surrounding the relevance of insulin as a driver of insulin resistance. So we have these three stressors, or noxious stimuli, if you will, on the pathological side: hyperinsulinemia, stress, and inflammation. Those are the origins of pathological insulin resistance. But on the physiological side, yes, insulin, elevated insulin is contributing to this, but so too is a new character, and that is growth hormone. In fact, to understand physiological insulin resistance, we have to appreciate the role of growth hormone. When growth hormone is elevated, among its many actions is an increased blood glucose. It will act kind of like the stress hormones were acting, without all the other negative effects, namely to promote glucose production by the liver. Increased blood glucose, of course, is putting it increasingly at odds with insulin, making insulin work harder and harder, and thus needing more and more insulin. And that is, of course, the definition of insulin resistance. So there are two states in the body that qualify as physiological insulin resistance. They are the two P's of physiological insulin resistance: puberty and pregnancy. In both of these instances, there is a need for dramatic growth. In the case of puberty, it's obvious the body needs to grow. In the case of pregnancy, it might be a little less obvious, although it shouldn't be. The mother's body needs to grow some tissue. The uterus needs to grow dramatically. The breast tissue needs to grow to prepare for lactation. And it helps for her to get a little fatter. She needs to grow some fat tissue to have that metabolic insurance that if calories became limited, she could have enough energy on her body to carry the baby full term. Not to mention feeding the baby once the baby's born, as it would have been done, of course, classically. But suffice it to say, well, and the baby needs to grow. It's helping baby grow in utero. But the combination of growth hormone and elevated insulin both help lead or fuel, or rather signal, this explosive growth. Signal is the better word. They act together to signal this dramatic growth. Now let's just look at each of these conditions in a little more detail, very briefly. So here we have the timeline of an individual progressing through infancy, childhood, adolescence, and adulthood. And I appreciate that my timeline here is in fact a little messy here, but you'll see that I have I have two axes here. Well, I have three, but here these two y-axes. So we have insulin resistance in the dark blue, and then insulin itself. And you can see that throughout infancy and childhood, the body's very insulin sensitive. And then once adolescence hits, we have this dramatic increase in insulin and this dramatic increase in insulin resistance. This is something that is very well reflected in individuals with type 1 diabetes. Look at their life as you see from childhood on through adulthood. You can see that the time when they need to be giving themselves, these males and females, the most insulin is right during puberty. And so as females go through puberty a little earlier, so too is the peak in females a little earlier than the peak in males. So you can see this, it's very well reflected, and really bringing home the fact that elevated insulin is a feature of insulin resistance always and forever. Now, if we go back to that earlier view and now we superimpose growth hormone, you see that growth hormone follows a similar trend, that it is low during infancy and childhood, and then it is dramatically elevated during adolescence, coming down at the end of adolescence and remaining low through adulthood. So those are the two, that's the first kind of instance of the physiological insulin resistance, namely puberty. Again, insulin is elevated. I will keep coming back to that to make sure we have a clear understanding of it. There is no insulin resistance, pathological or physiological, without elevated insulin. Now, in the case of pregnancy, we actually have a handful of extra signals here. We have the placental hormones. So we have the placenta, which is where little baby's growing, of course, or feeding the baby. It's kind of the interphase between mom's blood to baby's blood, or vice versa. We have these placental hormones. HCG is one that you all know about. HCS is this somatomamotropin, which helps with like mammary tissue development. And then we have human placental growth hormone. And in the mom, the human placental growth hormone actually overtakes her own production of growth hormone. Now, if we go back to a similar paradigm as I outlined with puberty, we see this very same, in fact, same view, where from pre-pregnancy to pregnancy to postpartum, once again, insulin resistance is elevated during pregnancy and insulin is elevated during pregnancy. And once again, let's look at what happens in type 1 diabetes, just because it's a perfect accounting for insulin. You can see that during the course of the pregnancy in a woman with type 1 diabetes, her insulin needs start to climb dramatically. It's almost getting to the point of doubling. It's getting really close to doubling her needs of insulin because her body's becoming insulin resistant. And now, if we look at that same paradigm and superimpose the human placental growth hormone, we see that once again, human placental growth hormone goes up, just like growth hormone did in the pubescent individual. But just as a reminder and an interesting point of physiology, in the case of puberty, it was growth hormone coming from the brain, from the anterior pituitary. It was the individual's own growth hormone, if you will. That's not a great way to say it, because even in the human placental growth hormone, that's still her growth hormone. But now it's just growth hormone from the placenta, not from her own brain. Okay, now to make matters even a little more complicated in pregnancy, because it is a very complicated state, we have the human placental growth hormone, but we also have cytokines, these pro-inflammatory molecules coming from the placenta, because many of them actually act to increase blood vessel growth. And as you can imagine, with all the growth in the placenta and the fetus and the little baby, you need a lot of new blood vessels to provide the oxygen, the metabolites, et cetera, for those growing cells. And so that's a good part of it. But of course, more cytokines means a greater potential for reduced insulin sensitivity. Okay, I hope that is clear. Now let's move into the final chapter, which is, does carbohydrate restriction cause insulin resistance? This is the debate. A lot of people will say that it causes physiological insulin resistance. Now, please remember, what is insulin resistance in either pathological or physiological? There are two parts of it. One is that insulin isn't working well and insulin is elevated. So with those two ideas in mind, does carbohydrate restriction cause insulin resistance? It is a heck no, it does not. It is a resounding no. There is no evidence whatsoever to suggest that a low carbohydrate diet is somehow creating insulin resistance in humans. Remember, and they will of course say it's physiological. No one's crazy enough to say that it's pathological. Remember, in physiological insulin resistance, there is elevated insulin and elevated growth hormone. Well, that doesn't jive with a low carb diet, because on a low carb diet, insulin levels drop dramatically in half or a third or so on, depending on the person. Insulin levels drop dramatically. Well, that immediately removes this possibility. But what about growth hormone? Well, growth hormone maybe changes a little bit, maybe a few points, but nothing to the level of what you see with puberty and pregnancy. But even still, it's a modest growth hormone change, if it's really changing at all, and there's varying evidence on that. And truly, it is very modest, and even the evidence that shows that it goes up. In no way could it account for any effect on insulin resistance. But even still, insulin levels aren't elevated. They are dramatically lower. So no, it does not cause it, because both of these origins of insulin resistance are neither of these is cooperating in a way that would cause insulin resistance. But what does happen, there is in fact a change in the metabolic state with a low carb diet that can be confused with insulin resistance. And that is that insulin production changes on a low carb diet. That is very important. And if we can understand that, and you will in a moment, then you can understand why the uninformed will say that a low carb diet causes insulin resistance. Now let's look at a different kind of timeline. This is the timeline on the order of minutes or a couple hours. And what we're going to look at is when someone takes an oral glucose tolerance test. So someone goes in and eats 50 grams of pure glucose. This would, or a couple slices of bread, it would be kind of comparable to that. So in a normal diet, like a standard American diet, but a person who is insulin sensitive, so they're eating normally all the time, kind of typical diet, but they're healthy metabolically. still for now. This is what their glucose levels would do. You'd see this rise and fall in glucose. And you can see my kind of legend here. The solid line is glucose. The hashed lines are going to be insulin. And this is color coding it here. So glucose levels rise and fall, and they pass the test. It's good. Insulin levels would look a little something like this. There's a few things to note here, or a couple things. And that is that, well, you can see it immediately, this biphasic progression of insulin. That there is a first phase, which comes and goes very quickly. And then there's a second phase. I've made it a little more dramatic. It doesn't actually tank like that. It just kind of comes up, scoops down a little bit and goes right back up. But I've made it a little dramatic for the sake of emphasizing it here. But again, there are two phases to this, of this insulin release. And remember, insulin is coming from the beta cell. So here we have a beta cell. And you'll notice in that beta cell, there's already some insulin in there. This is the beta cell being so efficient and determined to control blood glucose that it keeps some prepackaged insulin on hand. It's like there's this warehouse, and in the warehouse, we have all the machinery we need to make insulin. And then we have a stock, we have boxes of insulin piled up, ready to go out and get shipped the moment they're needed. And so this is very important. When blood glucose levels start to climb, like with an oral glucose tolerance test, that is like the factory getting a red alert, signal, alert. We have to start shipping out the product. We have to start moving the insulin. Well, the beta cell, acting as this little factory, it has some insulin already on hand because it knows that it needs to make a certain amount of insulin every so often. It has become used to the person's eating patterns, anticipating glucose coming in every few hours. That first phase is accounted for by the preformed or prepackaged insulin. However, at the same time that the factory starts shipping out the preformed product, it has hit the button to turn on the machinery to start producing more, because it knows this much insulin that I have on hand, it will not be enough. And so I'm going to just get that product out, and now I'm going to rapidly make more. And this new production, this de novo production of insulin, is what accounts for the second phase. And this is the beta cell's opportunity to kind of fine tune it. Whereas the first phase is just a dumping of insulin, knowing that it won't be enough, but it'll at least start to help to slow the curve of the glucose. The second phase is where the beta cell is now kind of getting a constant sampling, almost acting like a thermostat, a glucose stat, where it's thinking, all right, I need this much more insulin. Don't overshoot it. Just going to make just enough. All right, great, guys. All right, let's start to taper it off. It's working. Now the glucose curve has come down. So just remember, the first phase is the preformed insulin. The second phase is the insulin that it makes from scratch on the fly. Now, there they are again, good-looking glucose curve, good-looking insulin curve. However, if you take the average individual, in fact, this would be the average person who's following a standard American diet, and they're insulin resistant, now you have curves that look a little something like this, where you'll notice that the glucose curve, it not only started a little higher, in fact, if anything, I should have had to go higher than this, but suffice it to say, what doesn't happen is it doesn't come down as fast. That's kind of the key variable here. It doesn't come down as fast. That would be a fail of a glucose tolerance test. And you'll notice that the insulin secretion still has two phases. It goes much, much higher, but it has a first phase and a second phase. And the peak of the second phase is much later, which is a key feature of insulin resistance. If the peak of your insulin curve is around 30 minutes, that's a very, very good sign, and you almost don't need to look at anything else. Okay, but in this state, the person is insulin resistant and glucose intolerant. These are often the same thing, but not always. But if you say someone is glucose intolerant, which is what you actually know from a glucose tolerance test, you can't technically say they're insulin resistant. That's not the same thing. But in this case, they are going together. They have a lot of insulin, probably multiples more than what we saw in this other person. I'm just keeping it kind of scaled close. And yet it's not enough. They are insulin resistant, and there's a lot of insulin there, and they're glucose intolerant. Now, let's see what happens when we superimpose the curves of someone who's adopted a low carbohydrate diet and is insulin sensitive. their glucose levels look a little concerning. If they are adhering strictly to a low-carb diet and then just went right into the clinic and drank an oral glucose tolerance test, their glucose levels would look like that of someone who is insulin resistant or glucose intolerant. However, if you were to look at the insulin levels, you see something quite unique. It looks like this. Now, I have a lot of curves here, so it might be a little difficult to see, but you'll see that the insulin curve has just sloped up from its very low level, peaking around 30 or so minutes, and then it's coming back down. There is no first phase. There's only the big second phase, no first phase. This is a condition that we would say the person is insulin sensitive, but they are glucose intolerant. And this is where this is the origins of their confusion. They look at the glucose curve and think they know what's happening with the insulin curve. And so let's remove all the excess here and just go to this curve here. And you'll see again that there's no first phase. That's because this is not something unique to a low-carb diet. This also happens even with fasting too long. You could have an average standard American diet fed individual, and if they know they have an oral glucose tolerance test and they decide, oh, I'm going to fast for 24 hours to knock that thing out of the park, they will have the same thing happen. Basically, what happens is the beta cell gets the signal, even after a day of fasting, let alone years of adhering to a low-carb diet, that they don't need all the preformed insulin anymore because they never release it, or the amount of insulin they release is so little that it's not worth them trying to keep a bunch of insulin on hand. It just makes a little trickle of insulin all the time. And so if you immediately flush the system with glucose, like you do in an oral glucose tolerance test, the beta cells are simply not prepared because they've not needed to make a lot of insulin. So that is the key variable here, whether it's through fasting or a low-carb diet. It's not that the body is insulin resistant. It's that the beta cells don't have as much insulin on hand. And so if you load the system with glucose, it just takes them a little longer to make all that insulin. And thus, that's reflected in a glucose curve that takes a little longer to come down. So it would be kind of a false positive here, where they appear to fail the glucose tolerance test, but it's not for the reasons you'd expect. Now, and I'm going to come back to that idea in just a moment. So does carbohydrate restriction cause insulin resistance? No, but it can cause glucose intolerance acutely. So again, if you're going to go in and drink an oral glucose tolerance test, you will be glucose intolerant for that test because your body just has not been eating a lot of glucose. This brings up one final but, and I hope that you'll forgive me for bringing one final idea into this, but it's one that I think is just too compelling not to mention. And that's this phenomenon of what I call reverse metabolic inflexibility. I don't think anyone else has named it, so I'm just naming it that. I wish I could condense the name of it. Now, in a normal, healthy metabolic state, we have what's called metabolic flexibility, which is when insulin is elevated, the body is in sugar burning, blood sugar or glucose burning mode. When insulin is down, like during a fast, the body shifts over to fat burning mode. This is the phenomenon of metabolic flexibility. Metabolic inflexibility, as it was originally defined, was the state that is predominant with someone who has insulin resistance, which is that they have chronically elevated insulin, and thus even when they're fasting, their insulin is still high enough to force the body to stay in glucose burning mode. And thus there's very rarely moments of fat burning. This, again, they would say is metabolic inflexibility. They aren't shifting between the fuels. They're stuck burning glucose. That's the classic view. And again, that is insulin resistance. However, with chronic adherence to a low-carb diet or ketogenic diet, I think that can give rise to this reverse state where the insulin has now been down for so long that it's kind of like the body is stuck in a fat burning mode. And when you load the body with a bunch of glucose, it's difficult for it to shift over to glucose burning mode. And remember, it's simply because the person doesn't have the preformed insulin. They have to make the insulin from scratch. So they would fail the glucose tolerance test, but it would be kind of a fake failing. But thankfully, this is acute. The hack is very, very simple. If you know you have to go in to take an oral glucose tolerance test, then you eat carbs about 6 hours before you take the test. And look what happens. You bring that preformed insulin back. You basically remind the beta cells, hey, I'm going to eat some carbs. I need you guys to get some insulin on hand to help me have a first phase insulin release. And you'll turn that artificial failing glucose curve into the normal, healthy, insulin sensitive curve. And everything is working fine now. Now, my worry is that some of you will mistake what I'm saying, and you will think, well, Ben is saying that if I want real metabolic flexibility, I need to be eating carbs more often. If metabolic flexibility is your goal, then yes, you do need to be eating carbs more often. But if staying in a state of fat burning is your goal, then you don't need metabolic flexibility. We speak about metabolic flexibility as if it is the ultimate desire of all metabolically minded folks. And I don't think it needs to be. I don't think there's any reason for that. But if you want to be flexible metabolically, then you do need to eat carbs sometimes. Again, I'm not trying to defend that view and cycling and all that kind of stuff where we make it so complicated. I'm not. But I think it's an interesting point that we have the classic metabolic inflexibility, which is when the person's stuck in glucose burning because of their chronically elevated insulin. And then we have the reverse of that, the inverse of that, which is when the person's stuck in fat burning because of their chronically low insulin. But remember, that's just because the beta cells are too efficient. And their view is, if we're not releasing insulin all the time, we don't need to keep all of this insulin on hand. Well, thankfully, you can correct that as quickly as you'd like. Now, I realize that I'm not there to answer questions. I wish I were. In fact, maybe what I can do, Debbie can kind of prompt me. And by the way, Debbie, I should have thanked and acknowledged you. You guys, thanks to Debbie for arranging this for me and my wife. I so wish we could have been there, but I'm glad to have been able to share some of this. I can check the Facebook group. And if you guys just tag me in any questions you have about this talk, I'd be happy to get on there and answer some of the questions for you. Well, with all of that, safe travels, you guys. I hope you have a wonderful time on the trip, and I can't wait to go with you next year.